All the trials with BCG-unresponsive disease have started with cohorts with high-risk patients who are BCG-unresponsive and harbor CIS. The natural history of these trials has been having a new exploratory cohort after checking the efficacy in the CIS population with papillary-only disease patients. The thing is that among all the BCG-unresponsive patients, 90% of them will be papillary-only. So this is the biggest population in the BCG-unresponsive setting. The thing here is that after having seen efficacy for TAR-200 in the CIS population, Cohort 4 was designed to address and to see preliminary efficacy of TAR-200 in the papillary-only disease population. Well, we have reported in this Congress that TAR-200 achieves an 85.3% of disease-free survival at 6 months in the papillary-only disease population and 81.1% at 9 months. This is significantly higher than other drugs that have already reported results. Let's remind our audience that there are no approved options for these patients. The FDA-approved agents are for CIS with or without papillary disease, not for papillary-only disease. These results are not really comparable with CIS populations because for CIS populations, the main outcome, the primary endpoint, is usually complete response rate. These patients with CIS need some therapy to cure their CIS. And these patients with papillary disease only have a fully resected tumor. We check the tumors are fully resected before inserting TAR-200. So what we are looking for is a disease-free survival rate. We are doing some adjuvant therapy on these patients to avoid a high-grade recurrence. For sure, radical cystectomy is the current standard of care for all BCG-unresponsive patients, regardless of the CIS status, especially for the papillary disease only, where there are no approvals by the FDA. Radical cystectomy remains the only therapy for these patients, but radical cystectomy is a life-conditioning surgery. We know it has a very significant perioperative morbidity and mortality, and it has a relevant impact in the quality of life. Given this preliminary data, it is true that it's a short follow-up, it's a small number of patients, 52 patients, but like we have seen in the CIS population, in BCG-unresponsive CIS, Cohort 2 of SunRISe-1, I am sure TAR-200 has a potential to change the paradigm and the current landscape of this disease. Plus, there is an ongoing phase 3 trial, randomized trial, SunRISe-5, which is assessing the efficacy of TAR-200 versus intravesical chemotherapy in papillary disease-only patients who are BCG-unresponsive or BCG experienced. And this will provide additional data on the efficacy of TAR-200 in this population. We still don't have data about the quality of life questionnaires, but we have data on safety and tolerability, which were secondary endpoints of this trial. We know that most of the adverse events are grade 1 or 2. They are mainly related to lower urinary tract symptoms, and the resolution is quite rapid after the onset of the toxicity. Only 3 patients in the cohort experienced serious adverse events, and only 4 patients had to discontinue the therapy due to toxicity. So this is very relevant, showing that it is a very well-tolerated therapy. Also, there were no treatment-related deaths, and regarding the ease of administration of TAR-200, we assessed that 99.5% of the insertion procedures were successful. Well, it's true that the scenario of BCG-unresponsive CIS is really crowded, and there are a lot of trials, 3 approvals so far by the FDA, no approvals in Europe, which is my environment. TAR-200 has a big advantage, in my opinion, and it is that it guarantees that there is a continuous and sustained release of the drug inside the bladder. So the bladder mucosa, the bladder wall, will be exposed to continuous delivery of the drug during 3 weeks. Also, we demonstrated in the Penelope study that the administration of gemcitabine with TAR-200 versus usual administration with a normal instillation significantly increases the penetration of the drug across the bladder wall. So we may reach deeper layers of the bladder wall that we won't reach with usual instillations. Nevertheless, we have some preliminary data from some trials and some other drugs, and as we know, we should not TAR-200 has very promising results above the average over all the other alternatives, but we should not compare across trials. So in the future, probably, we'll have to learn to combine, sequence, and even do trials comparing these new agents one versus each other. Well, the future steps is really SunRISe-5 with this randomized trial. And regarding the bladder cancer situation, we are really happy that bladder cancer 10 years ago had nothing new, and now bladder cancer is at the prime time in the plenary sessions, and we have a brilliant future, especially for our patients. And in the future, I'm sure we will be able to save and spare more bladders than we are doing now.